Fibrillation is a spectral disease and not a single entity. So let's go ahead and get started. In a normal heart, you have SA node and AV node, and the SA node is an automatic pacemaker of the heart that sends a signal to the cardiomyocyte conduction fiber cells, and in a normal person, it goes nice and smoothly to the Purkinje fibers, and all of what this means is that all of the heart muscle, and also it sends it to the left atrium as well, because in a normal heart, the tricuspid and mitral valve open and close simultaneously. So if you get the contraction of the left and right atria with using all your cardiomyocytes, you get the best blood flow into the right and left atria, and then it goes down to the right bundle branch and the left bundle branch into the Purkinje fibers, which ultimately contract the right and left ventricle. And you need that signal in order for it to contract fully, right? And then you see an atrial fibrillation, because the tricuspid and mitral valve aren't closing at exactly the same time, it causes the pooling of blood, and there's two causes of AFib. You can have like a wavy conduction fiber, and if the SA node brings it to that, it can trigger episode of AFib, or you can have what's called a automatic theory of AFib, which is what I would want if I wanted AFib, because it's usually located by pulmonary veins, and you just locate it and ablate it and you cure the disease. But you can see how if the blood is here, what happens is the left atrial appendage, with progression, you get blood clots, but not early in the disease. This, we're talking elderly. They'll have blood clots here, they'll have blood clots here, scarring of the endometrium, and so forth. But so assume you have a patch of cardiomyocyte fibers that aren't nice, smooth, and parallel. You get less of a signal to the AV node, and what happens is, what that means is the Purkinje fibers don't contract hard enough, and you get less cardiac output. The classical EKG is the sawtooth pattern, absence of P waves, and irregular PR intervals for AFib, typically in V1, AVF, and coronal lead 3, but you can also see it in some other leads. Anything can happen in medicine, so as we know. This is the same thing, but what I just found a study that they took a cohort of young patients with lone AFib, and they measured the size of their left atria, and they found that they cured 80% of young patients with lone AFib with cryoballoon ablation, and it was a cure. And the 20% that had recurrent episodes, it was consistent with a larger atrial size. So they concluded that the larger the atria, the less likely ablation will cure, and you'll have a recurrent episode. This is simply a picture of blood clot formation, because blood clot formation happens when you have just blood swirling around, because the valves aren't closing and opening, and it predisposed blood in the left atrial appendage. This is late AFib, more continuous, and it can cause a stroke. So that is the reason for that. So going back to the study of how they treated 80% of the young patients with lone AFib, what I like about this study is they measured the left atrium here in C and D in 3 dimensions to get the most accurate left atrial volume instead of just doing one view. So they did parasternal long axis, 4-chamber, and so in C they did the 4-chamber view, which gave them the superior to inferior length, and then in D they did the 2-chamber view, which gave them the anterior posterior view. So it created a 3-dimensional size of the volume of the heart. The other thing that they did good was they did a trans Doppler color echo in order to measure the flow of blood from the left atria to the left ventricle. So causes of AFib are mitral valve disease, such as stenosis, rheumatic heart disease, and mitral regurg, as well as cardiac myxoma, and some inherited causes I won't talk about, but you get the idea. The bigger the left atrium, the more likely that the conduction fibers lose their nice linear parallel flows in order to produce the highest contraction. And this just says the points they use to measure the inferior or the superior to inferior, and the points they used to measure the posterior to anterior. Again, this is the normal heart. The key in AFib is that the tricuspid and mitral valves do not synchronously open and close, which causes the blood to stay here, less cardiac output. And the reason pulmonary hypertension, so to the lungs, the capillaries are vasoconstricted due to pulmonary hypertension, which means the right ventricle has to pump blood. It's harder for it to pump blood against hypertensive pulmonary hypertension. And in addition to that, it has less blood because, especially during an episode of AFib, more blood stays in the right atria, so it's doesn't have much volume to pump. And remember, the conduction fibers are all messed up during an episode, so the Purkinje fibers here can't contract fully, so you get even more backflow until the episode stops. So the study also did a color Doppler mitral inflow peak, early diastolic peak atrial systolic velocities, and deceleration times. Basically, in this video, what I'll show you is that you can tell how there should be a set amount of blood being pumped from the left atrium to the left ventricle and then to go to the aortic trunk, right? But in an AFib episode, that does not occur. So here you can see that the mitral valve and the tricuspid valve are not closing at exactly the same time. So we got some fibrillation here, and then the color Doppler tells you if there's regurg back into the left atrium due to mitral valve disease or anything else, or if there's pulmonary hypertension and the left ventricle can't pump against it during acute episode of AFib, it regurgitates back into the left atrium, and that's why this disease is progressive, because the more attacks you have, the more your left atria enlarges. So this is the automatic focus theory. Basically, these are your pulmonary veins, and you can have a foci, and if it's ablated, it can just be ablated, best form. Now, this is your more common AFib with the aberrant conduction fibers, and this just shows that not only does the blood pool up in the atria, but also the conduction fibers are all messed up, so you can't get as strong of a contraction in the ventricles. It's treated with stroke prevention, rate control, maintenance of normal rhythm. We're talking late onset, but remember, let's explain why it's progressive disease. So first, you start with paroxysmal AFib. The red lines indicate episodes of AFib, and as you can see early on, you have very little. That's why it's important to catch the disease early so you can do an ablation. Maybe here you could do a surgical ablation with a scalpel to remove more aberrant conductive fibers. You probably can't do anything at this point, and definitely you can't do anything once you have permanent AFib except treat with drugs, possibly add a pacemaker, but you do rate and rhythm control if you really know what you're doing. Usually it's rate control, but you can add rhythm if you're a rock star, and stroke prevention with blood thinners, because remember, by the time you're at this point, you're going to have blood clots in the left atrium and left atrial appendage. The next slide is an EKG of a young healthy male in an active episode of AFib. You can pause the video if you want to see if you can detect the abnormalities. And so this whole one is transverse V1. So you see absence of PE waves. These everywhere you have the jigsaw pattern, irregular PR intervals, and no P waves. And then you also see it in AVF and V1 and lead. I don't see coronal lead 3. Let's see if we can find coronal lead 3 in this. Coronal lead 3 has a little bit less jigsaw pattern, but anything can happen. This just shows on EKG right atrial enlargement is indicated by tall P waves. And here is the higher the peak and the wider the P wave, the more the right atria is enlarged, and a same goes with left atrial enlargement. First of all, a diaphasic P wave can be normal, and if you see sloping ST segment elevations in every lead, that is normal for athletes, because it's definitely not a myocardial infarct, because it would be impossible to get every type of myocardial infarct at the same time and in an otherwise healthy athletic person. But anyways, the left atrial enlargement is measured by the same way. Instead of the P, it's the T wave is large. And that concludes my presentation. Basically here you see causes of left atrial enlargement, subsequent risk for progression of AFib. Remember the diseases that can increase chances of AFib are like myxoma, left atrial myxoma, mitral regurg stenosis, pulmonary hypertension. AFib can cause AFib, or left atrial enlargement caused by mitral valve disease or pulmonary hypertension can cause AFib. Yeah, so that's about it. Thank you for watching. Please leave any comments, and I hope you found this video useful. Thank you.